And again, wanted to welcome everyone to today's webinar. My name is Derek Mitchell. I'm an event producer with Mathematica. Thank you for attending today's Medicaid and CHIP Maternal Health webinar series. This is the fourth webinar in the series titled Addressing Hypertension Before, During, and After Pregnancy. Before we begin, we want to cover a few housekeeping items. Next slide. All participants logged into this webinar have been muted for the best sound quality possible. Closed captioning is available by clicking on the CC icon in the lower left corner of your screen. You can also click Control-Shift-A on your keyboard to enable the captioning. We welcome audience questions throughout today's webinar through the Q&A panel, which is located in the bottom right corner of your screen. If you would like to submit a question, please select all panelists in the drop-down menu and then click Send to submit your questions or comments. We'll be monitoring the Q&A throughout the webinar and will address as many questions as possible. If you have any technical issues, please use the same Q&A panel to reach out to us. Select Derek Mitchell in the drop-down menu and then click Send to let us know how we can help. At the end of the webinar, a survey will pop up in your browser window. We're asking you to please respond and provide feedback to improve future webinars. We also want to let everyone know that today's webinar is being recorded. We will send an email to all meeting registrants when the slides and recording are posted on Medicaid.gov. Next slide, please. Here's an illustration on, again, how you can submit questions and comments throughout today's webinar. Next slide. Now, I'd like to turn it over to Lakeisha Daniel Robinson from Mathematica. Lakeisha, you now have the floor.
Thank you, Derek, and welcome everyone to Medicaid and CHIP series addressing hypertension before, during, and after pregnancy. I'll be serving as your facilitator today. We have a robust panel and discussion about the impact of hypertension and cardiovascular conditions during pregnancy, before, during, and after pregnancy, and the opportunities to address them. And we'll hear from representatives of the CMS Center for Medicaid and CHIP Services, the Centers for Disease Control and Prevention, the California Maternal Quality Care Collaborative, and the Oklahoma Health Care Authority. We will follow with an opportunity for your questions and discussions. I'd like to now turn things over to Kristen Zeicherman, the Quality Improvement Technical Director for the Center for Medicaid and CHIP Services. Kristen?
Thank you, Lakeisha. And on behalf of CMS, I just want to welcome everyone and thank you again for joining another great webinar in our summer webinar series. We will be the objectives for today are to provide an overview of the CMS Maternal Infant Health Initiative and opportunities to improve maternal health outcomes in Medicaid and CHIP, describe maternal hypertension and its contribution to maternal morbidity and mortality, share information about CDC's new hypertension and pregnancy change package, and California and Oklahoma will describe some state strategies to improve screening, treatment, and care coordination of hypertension and other cardiovascular conditions in Medicaid and CHIP delivery systems. Next slide, please. This is our standard historical slide of the Maternal Infant Health Initiative, which if you've joined our other webinars, you've heard me describe before, but it was launched in 2014. And kind of fast forwarding, our newest offerings of this summer webinar series, followed by 2 affinity groups in the fall, addressing maternal mental health and substance use, as well as maternal hypertension and cardiovascular health, which this webinar focuses on, are leading drivers of maternal morbidity and mortality. And so we wanted to specially address them in this newest phase of our Maternal and Infant Health Initiative. I also love to plug our website, and I encourage you to go and check out the Maternal Infant Health Initiative website on Medicaid.gov, because we have a lot of great QI offerings and resources related to maternal and infant health on topics that we've covered previously in MIHI, as well as that's where our previous webinars live for this webinar series as well going forward. So encourage you to do that. And thank you again all for joining. And I'm going to hand it back to Lakeisha. Thank you.
Thank you, Kristen. And we've put information in the chat as well. We have some links at the end of the webinar, and the slides will be posted within a couple of weeks. But next slide, please. As Kristen talked about, hypertension and other cardiovascular conditions are leading drivers of maternal morbidity and mortality. Here we present information that 21% of female Medicaid beneficiaries, generally speaking in the reproductive ages, have been told at some point that they have high blood pressure. This data is also stratified by age grouping and race and ethnicity. These rates are higher than the national rates during pregnancy that will be presented by the CDC in a moment, but importantly shows how high the prevalence is within Medicaid and CHIP among female beneficiaries overall. With that, I would like to introduce Dr. Wright, Director of CDC's Division for Heart Disease and Stroke Prevention, to discuss the problems and solutions of hypertension in pregnancy. Dr. Wright.
Thank you so much, Lakeisha. And I want to thank my colleagues at CMS and CMCS for this wonderful opportunity to bring you some additional information about the problem that we're facing as a nation and to offer some solutions. If there's one word I'd like you to attach to this presentation, and that is that I'm bringing you a resource. And I hope it will be useful to you in your work ahead. Next slide. I'll start by just stating the problem. This is a case for hypertension and an intense and sustained focus on hypertension in the country. What I'm going to cover applies to hypertension broadly in the population and quite specifically to women of reproductive age and those who experience a pregnancy. First of all, it's common. Broadly in the population, 1 in 2 of us US adults has high blood pressure, and the control rates are less than 25%. So out of people with hypertension, only about a quarter of them have blood pressures that are what we would consider safe and under control. The impact of undetected and uncontrolled hypertension is immense. It harms all body organs and is also associated with complications in pregnancy. The specific and intensely painful aspect of hypertension in pregnancy for me is that the damage done, the harm done is lasting. It affects not only that person during pregnancy, but it marks her for the rest of her life to have an elevated risk of heart disease and stroke. That risk starts to present itself earlier in her life than it might otherwise. And it also marks the offspring of that pregnancy for an elevated lifetime risk of heart disease and stroke. The next bullet, we are losing ground, both in the population generally. We are seeing control rates lower than we have in the past decade. So we're literally losing control of hypertension, and the prevalence of hypertension is increasing. That is also true of hypertension in pregnancy. We know that hypertension is inequitable, and the slide that Letitia showed documents that as well. We know that Black women, Native women, Native Hawaiian and Pacific Islander women all have higher prevalences of hypertension and hypertension in pregnancy, and control rates are lower. Within hypertension in pregnancy, we see higher prevalence and lower control in those individuals, both generally in the population and pregnant individuals who live in rural environments, people who live in the South and in the Midwest, mothers who are age 35 and older, and also mothers who are in the lowest median income bracket. So many types of inequities are present in hypertension in pregnancy. The next bullet is about hypertension being costly. And the first cost, of course, is that it harms individuals and it devastates families. It affects workplaces and whole communities because of these largely preventable events due to undetected and uncontrolled hypertension. The dollar amount is also costly in that the estimates are $131 to $198 billion annually from hypertension. And that is an underestimate because it does not take into effect the lost productivity that comes from hypertension-induced events like stroke. This sixth bullet is my second favorite bullet on the slide. That is that, thank goodness, what works to detect and control hypertension in pregnancy is known. We know what works. And of course, it's time for all of us to help make that what happens throughout the country, regardless of section of the country, zip code, race, ethnicity, and the other factors that I've mentioned. But my favorite bullet on the slide is that this is an opportunity for us to have a generational impact. As I mentioned, by addressing hypertension prior to and during pregnancy, we not only impact the life and health of that person, but also of the offspring from that pregnancy. So next slide, I'll just walk through a couple of data slides. First of all, this one will knock your socks off. This reflects 32 million births in the United States between 2010 and 2021, showing this dramatic rise in hypertensive disorders of pregnancy. That includes chronic hypertension. It's really a stunning increase. And if you look at the relative increase over that period of time, it's about 113% increase. On the next slide, I show this slide captures the high risk factors for preeclampsia, sort of one at a time. Preeclampsia is one form, as you know, of hypertension in pregnancy. Here, a gentle rise, but a definite rise in pregestational diabetes, which is a high risk factor for preeclampsia over this same period of time. On the next slide, we see a reduction in multifetal gestation. That too is a high risk factor for preeclampsia, but we've seen a decline there. The next slide shows a primary driver for why we are seeing increasing rates of hypertension in pregnancy. This represents a 125% increase, more than doubling of chronic hypertension. And what I want to make sure I emphasize here is that this is likely an underestimate because of the way we measure hypertension in individuals. So next slide. I just want to bring to you, again, a slide that's a take-home slide showing the complications both for the fetus and for the mother, both in the short term and the long term. Next slide. I'll go quickly through the remainder, but the solutions I'm bringing to you today are contained in this hypertension and pregnancy change package. The strategies listed over on the right are those for which there's a strong evidence base for each of these, and we have collected over 350 tools and resources from around the country, tried and true, road-tested strategies that support the improvement of quality delivered in outpatient settings for people who have been pregnant or in the postpartum period. Next slide. I'm going to go through these quickly just to show you are QI experts on the call today, and we have on the left the interventions I mentioned, and on the right examples of strategies that can be implemented according to the characteristics of the population served and the priorities within clinical settings. Next slide. I'm going to skip through, just go ahead, skip through these. This just shows you change concepts, change ideas, and then examples of the tools that are ready and customizable based on the priorities of the practice or health system in question. Next slide. I show this slide because we have learned that antihypertensive medicines that are safe during pregnancy are not uniformly prescribed. And so this is an excerpt from the change package that allows clinicians to look and see which medicines are safe and get those in the formulary. So this is clearly a QI intervention. Next slide, or click forward. No ACEs and ARBs. Next. There are also a list of medicines that are safe during lactation. Next slide. Thank you. And then we know that aspirin, there are clear, strong evidence base for aspirin used to prevent preeclampsia. This slide is an excerpt that shows the high risk features and the moderate risk features. Next slide shows the amount of money that can be saved. If aspirin were prescribed according to those guidelines, it's over $350 million in projected cost savings. Next slide. There in the change package, there's this diagram which shows the proper technique, which allows us to prevent overtreatment and undertreatment and the most accurate diagnosis for hypertension in pregnancy. Next slide. These are resources showing coverage for SMBP for monitors, that is, validated monitors, accessible and by state. And we keep this up to date working with our colleagues at AMA. Next slide. Patient information about the warning signs of preeclampsia are included in the change package. Next slide. And then we have a list of things here where Medicaid and CHIP programs can get started. These are all extracted from the change package and happy to discuss those further with you. I'll just close next slide showing our Action Forum, which will convene. The inaugural meeting is on August 6th. The link to join and register will be in the chat. This is a place for implementers and potential implementers to come together, exchanging best practices, identifying solutions, and sharing resources to accelerate the detection and control of hypertension in pregnancy. Next slide. I would ask for you to do the best you can to disseminate this change package, to join our Action Forum. By all means, help facilitate the implementation of these proven interventions in the people and the partners that you reach, and help us improve the change package over time. Final slide. Thank you. There are resources here. I won't elaborate on them. You'll get access to this slide deck. And I think I have a final slide with some contact information. Please reach out to me or to Hillary Wall, who has helped pull this change package together. And we look forward to working with you. Thanks very much.
Thank you, Dr. Wright. We'll now turn to Dr. Amanda Williams, an OBGYN and Clinical Innovation Advisor with the California Maternal Quality Care Collaborative and Stanford University School of Medicine, who will provide additional perspective on disparities and drill deeper on actions and a toolkit. Dr. Williams?
Thanks so much. And if you could advance our slide, I appreciate the opportunity to represent both the CMQCC, the California Maternal Quality Care Collaborative at Stanford, and our National Admission Advancement Council at the March of Dimes. Next slide. So what I'm going to do is introduce you guys a little bit to CMQCC and then some of our tools that we've developed for hypertension, both detection, treatment, and then our newer work in our low-dose aspirin initiative around preeclampsia and preterm birth prevention. Next slide. So for those not familiar with CMQCC, we are our state's perinatal collaborative, and our mission is to end preventable morbidity, mortality, and racial disparities in maternity care in California. We've been around for 18 years and work hand in hand with the California Department of Public Health to take what we learn in our maternal mortality reviews, and I'm privileged to be part of the Maternal Mortality Review Committee for the state of California, and not just grieve the deaths of the people who have lost their lives in this pregnancy and postpartum period, but take those losses and move them into action and really think about how can we do better, how can we learn and help our member hospitals. And every hospital that has maternity services in the state of California, and we are a huge state, 1 out of every 8 babies in America is born in California. So we believe if we can move California, we can move the nation. And we do have the lowest maternal death rate in the state, in the United States, in California. And we like to think that a part of that is the collaborative work that we do in addition to good policy and care provision. We're also the effector arm of the March of Dimes Prematurity Research Center. So again, taking research, taking these maternal deaths and putting them into action. Next slide. So our secret sauce is the Maternal Data Center. And what that is we take all of our member hospitals, all 2011 hospitals, and we get ICD-9 and 10 codes, procedures, et cetera, from those hospitals, monthly uploads. We have quality nurses doing some manual reviews, both at the hospital level and at the CMQCC level, and then marry that with our vital statistics, birth certificates, death certificates, state newborn screening, and put that together in the maternal data center, linking the parent and the child, and then creating an interactive analytics tool for our hospitals to use so that they can then do QI interventions. We, with particular topics, then run collaboratives, whether it's sepsis, hypertension, community birth, supporting vaginal birth, preventing primary C-sections, et cetera, and create these collaboratives that bring hospitals together of all different sizes and geographies to learn from each other, share best practices, really engage our hospitals so that we can then move forward, develop our toolkits, and then make them available more broadly. Next slide. So we know that the reason this is all necessary is because of the maternal mortality crisis that we have in our country. Next slide. And we know that this burden is not equally shared. So not only is hypertension not equally shared across different races, ethnicities, insurance types, we know that maternal death isn't either. And for Black and Indigenous birthing people in this country, even when you adjust, and that research did come out of Stanford a year and a half, 2 years ago, for education, so for our college educated Black women, or for income, our highest income quartile in the state of California, our Black birthing patients are still twice as likely to die, and their newborns are twice as likely to die. So if it isn't education, if it isn't money, and those things being sort of slang, if you will, for access or big drivers of access, then what is it? And what is the what are many different things, but we cannot forget the impact of bias and systemic racism. And so that is incorporated into all of this quality improvement work that we're doing in California. Next slide. So while we do have the lowest maternal mortality rate in the country, our disparities in California are, while they are improving, and we're super proud of them improving, they are still just as bad as the rest of the country. So this is where my work comes in, and I am proud to lead it. Next slide. And so this takes a closer look. So this is California maternal deaths between 2012 and 2020. And we're looking at causes of death. And for those who don't recognize the acronyms, the main drivers of maternal death in California are, like most of the country, cardiovascular disease, hemorrhage, infection, hypertensive disorders of pregnancy, venous thromboembolism of different types, and amniotic fluid emboli. And what we're talking about today, these hypertensive disorders of pregnancy, that's the light pink. And as you can see, for Black patients, that they are disproportionately impacted by hypertensive disorders of pregnancy. And I want to just double click on that little writing under where it says Black, which is scale. And the scale is 1 to 3. So when you let that sink in, that Black patients die during pregnancy and postpartum so much more than their peers, their other peers from other races and ethnicities, that they don't even fit on the slide. You'd have to line up 3 slides and they'd still be the longest bar. So, when those patients look like me and my sister, that makes an impact. And this is, again, a big piece of what inspires my work. Next slide. Fortunately, in California, because we have our toolkits, because we're so engaged in this work, we have seen improvement. And so again, this is our California maternal mortality, looking from different causes. Again, the pink is the hypertensive disorders of pregnancy. And you can see the last 2 time periods with these green arrows, there has been a 75% reduction in maternal death from hypertension. That is awesome. And we're super proud of this work and we want to share it with you. Next slide. So, what is in our hypertension toolkit? What is it that we're doing? Next slide. So if you go to our website, which is just cmqcc.org, you'll see on the left-hand side our different initiatives and collaboratives that we have going on. And this is what it looks like to go into the hypertensive disorders of pregnancy section. And this is open to the public. There are parts of the site that are just for California hospitals, but this is open widely. And we do want this work to get out across the country. Next slide. So specifically, what's in there? There are slide decks, there are webinars, there are algorithms, and it was neat to see our algorithm in Dr. Wright's slide that's in that broader package, bringing tools together from around the country. This is our suspected preeclampsia algorithm. But this is a multifactorial issue. And all of you who do QI know that multifactorial problems require multifactorial solutions because we don't know what's the one thing that's going to make a difference for that particular patient and her baby. And so we've got debrief tools so that we can learn for when things go wrong. We have order sets for your EMR. We have scripts. We have posters, all sorts of things in this toolkit. Next slide. So for example, on the left, that's a copy of a poster that can be downloaded, laminated, put into the emergency room to help us identify pregnant patients. Because we know that oftentimes in the postpartum, people aren't even being asked, were you recently pregnant? And so we want our ED colleagues to really be engaged and be thinking about specific risk factors. And, there's lots of great tools inside the Hear Her campaign from the CDC to help educate families, in addition to providers and patients, about what to be looking for if a patient has recently been pregnant. We also know that the vast majority, indeed in California, it's 92% of the maternal deaths associated with hypertensive disorders are after the birth. So let me keep moving forward. And we know that we don't just have scripts, we have discharge follow-up so we can figure out how to leverage technology in order to get blood pressure checks done, in order to make sure that patients are getting appointments, tracking symptoms. These are all part of our toolkit. Next slide. Now, our new avenue is in prevention, and Dr. Wright talked a bit about low-dose aspirin to help prevent preeclampsia and preterm birth. Next slide. So I'm not going to go into details about it, but especially for our community members, public health colleagues, getting the word out that so many patients are candidates for low-dose aspirin to start around 12-ish weeks, continue through pregnancy, and there are huge benefits, not just for the mom, but also for baby, in order to prevent preeclampsia, prevent preterm birth. Next slide. Yet we know these recommendations have been very slow to become adopted. And even patients with chronic hypertension, who are the highest utilizing group, only 50% of them are taking them. And among Black patients, it's only 10%. So we have work to do. Next slide. So instead of just saying, oh, they're not listening, we have to be more humble. We have to ask, what's getting in the way? Is it about the pharmacists? Are we having a hard time getting prescriptions? Is it with difficulty with pill taking? Is it fears about medication? Is it the mixed messaging that's going on? Is it stigma about the risk categories like race, SES, social economic status, obesity? We have to think about those barriers. Next slide. And so these are some of the steps in our collaborative that we've been taken. And I'm just going to click through a few slides here so that you can see some of the work we're doing. So for example, this is some of the educational material that's going up in the clinics. Next slide. You can see the self-assessment tool that takes the more complex list of risk factors that Dr. Wright showed and make it in a patient-friendly fashion so that patients and their families can assess. We're doing site visits in order to work with the clinics. Next slide. We're doing educational webinars, and these are not just for California. These are open to everyone, teaching providers how to discuss risk respectfully, working with community members. We have a doula webinar. We have a webinar for pharmacists, really trying to engage all the people who are part of this process. Next slide. And then really engaging our patient advisory committee. These are all paid experts in this live experience and making sure that their voices are there and that we listen to them. Next slide. And then finally, we have the data support. So helping our clinics and hospitals build the data tools that are required. Next slide. And then we integrate that into our maternal data center and the QI interface that they might use for hemorrhage, they might use to track their C-section rates, they can use it to track around low-dose aspirin usage, and then stratify. Everything in here can be stratified by Medicaid versus commercial pay, by race, ethnicity, etc. Next slide. And I think that is it. Yes, for me, this is me and my preeclampsia NICU baby many years ago, and now he's off at University of Michigan. So this work is both personal and professional for me, and I'm proud to do it with March of Dimes and with CMQCC. Thank you.
Thanks for sharing information about your own lived experience in addition to the work that you're doing in California. I'd like to now turn to Carrie Edwards, an RN and Chronic Care Management Supervisor with the Oklahoma Healthcare Authority, along with Amy Allen, RN, who is a Population Care Management Supervisor, who will talk about working with Oklahoma Medicaid members with cardiomyopathy. Oklahoma.
Thank you so much. Good afternoon from Oklahoma. My name is Amy Allen. I am here with my colleague, like she said, Carrie Edwards. We are both supervisors here at the Oklahoma Healthcare Authority. I'm over the obstetrical program, and Carrie is over the chronic care unit. We are excited to be here today and to share with you our journey on how we began case managing the perinatal cardiomyopathy in our departments. Next slide. So how it all started, just to give you a little background, in June of 2021, Oklahoma became a part of the CMS Improving Postpartum Care Affinity Group Project, working with our agency partners, the Oklahoma Perinatal Quality Improvement Collaborative, Oklahoma State Department of Health, the Oklahoma Mothers and Newborns Affected by Opioids, and other Oklahoma collaboratives that did a lot of the foundational work that helped us focus on the area to work on for our project. We also utilize the Member Advisory Task Force, where we take member feedback for sooner care concerns. So there are 4 different PDSA cycles that we started for Oklahoma within this project. In my area, I started one PDSA looking at the proposed goal at how to reduce the rate of maternal mortality in African American and American Indian women with chronic conditions to determine if we actually case manage these women or birthing people through the 12th week postpartum, will it increase the postpartum visit rate? And then secondly, if they need a referral for chronic condition management, will that be made? Our efforts to begin with were to case manage 5 women with 1 nurse in our population care management department during pregnancy and through the 12th week postpartum. This nurse was to use motivational interviewing, open-ended questions, appointment reminders, surveys like the EPDS, and other things like helping members obtain meals, lodging, and transportation. We also discussed important topics with mom on pregnancy stages, fetal growth and development, labor, delivery, safe sleep, breastfeeding, family planning, tobacco cessation, drug use, and comorbid conditions, as well as follow-up care with the OB for the postpartum visit. We made calls monthly to members and continued this through the end of their pregnancy and into the 12th week postpartum. After the 12th week, we completed a warm handoff to our chronic care unit and let them assist them with their chronic condition after pregnancy. We completed 2 full PDSA cycles, as you can see on the screen. In our PDSA 1, we took 5 women with chronic hypertension and diabetes mellitus that were African American and American Indian. And what we found, as you can see in number 1, I'll let you know that all women delivered. In number 2, 40% attended their postpartum visit. In number 3, 20% or 1 out of the 5 discussed their chronic condition with their provider. In number 4, 60% had drug use in pregnancy. And number 5, 40% had to have a CPS referral or a Child Protective Service referral completed at some point during case management. In our PDSA cycle 2, as we moved these same 5 women to case management with our chronic care unit, we found out that all of our women were sent to chronic care unit in number 1. 20% were currently active with case management when our PDSA cycle ended. Number 3, none of the women accepted any additional resources from the chronic care unit. Number 4, 40% of the women had seen their PCP or specialist, and we found that via claims and calls. Number 5, 20% discussed their chronic condition with their provider. And number 6, only 60% were unable to be contacted by the chronic care unit in general. Next slide. So now what? We felt at this point that we needed to pivot. We did not see that our PDSA was fruitful for the work that was being done. We investigated looking at some of the research, and in the Oklahoma Maternal Health and Morbidity and Mortality Annual Report of 2022, we noted that 60% of the deaths over the most recent 5-year period were determined to be preventable. We also noted that for African American and American Indians, one of the highest causes of death is hemorrhage and cardiomyopathy. So with that in mind, our analysts pulled the data for Sooner Care and noted that there were over 30,000 births with Oklahoma Sooner Care, which is 1.5% of women that had developed cardiomyopathy before, during, or after delivery. And that was 450 women that could have potentially been reached by our departments. And we felt this was also in the vein of the chronic care unit and that they would be a needed part of this collaboration. Next slide. So what we did with that is PCM created cases on the current pregnant members that met the criteria for cardiomyopathy. We sent introduction letters. We mailed materials of healthy pregnancy, unable to contact letters if members were unable to be reached by phone, and then closure letters when they were sent to the chronic care unit or if PCM closed the case. We made monthly calls using the same motivational interviewing, open-ended questions, giving education or appointment reminders, completing the healthy pregnancy survey to find other barriers, as well as the PHQ-9 to monitor for depression. We used care plans to allow for continuity of care, giving members all the same education we give all of our other obstetrical members, with the focus on their cardiomyopathy concerns, as well as other comorbid conditions. We then gave warm handoff to our chronic care unit for continued case management. Next slide. During PCM's case management efforts, in about an 8-month period, we have case managed over 59 cases. And what we discovered was difficulty once again in reaching our members or engaging the members on the phone. We found that many Sooner Care members change their phone numbers frequently or they run out of minutes, thus making phone calls difficult. Oklahoma expanded postpartum coverage to 1 year, which gave our members more time to be reached by the chronic care unit after delivery, which actually was a huge win as we normally had only 2 months coverage and now it is 1 year. Prior to expansion, we were able to identify pregnant women with eligibility aid category of a P1, and we then got expansion or the HAP, and this changed or masked our ability to view members who had eligibility due to pregnancy. And lastly, Oklahoma began managed care, which took the non-disabled, non-tribal citizens, as well as any tribal members who would choose to opt in into managed care. And thus our population that we case manage now are the disabled and the Native populations if they choose to opt out of managed care. One area that we found that seemed to have a potential connection to cardiomyopathy is a diagnosis of anemia. When our nurses viewed claims, we are not sure if this is significant, but it's something that we have noticed as a possible connection. Next slide, please. Moving forward, since one of the populations that we have been case managing is Native American or American Indian, that we have been focusing on with cardiomyopathy, our unit decided to start case managing all of our American Indian pregnancy population with the Healthy OB Outreach Program. In Oklahoma, we have 39 recognized tribes, and from our American Indian Fast Facts, we found that of all Medicaid members, including traditional Sooner Care, Sooner Select, Managed Care, and Insure Oklahoma, that 17% of the enrollments are that of a Native population. Next slide, please. For Oklahoma Sooner Care alone, non-tribal is there in blue at 67%. Associated with the tribe is in orange at 31%. And then we have 2% in gray are those of a tribal population that are tribal affiliated, but they do not affiliate with a name. That is around 33% of our population with Sooner Care that is considered tribal. Lastly, in our high-risk OB programs, where most of our cardiomyopathy members would typically fall, we found that 17% are Native and 38% are those that we case manage currently have cardiomyopathy and Native and American Indian citizens already. Other areas that we focused on is substance use disorder, which we have collaborated with our OU Perinatal Hospital partner to be a part of their STAR or Substance Use Treatment and Recovery Program to help keep moms and babies together while getting treatment, as well as focusing on mental health for these members. Next slide. As we complete our care management and after the postpartum call with our cardiomyopathy members, we give a warm handoff to our chronic care department with Carrie Edwards. And I'm going to hand this over to Carrie to let her discuss the care given from the chronic care department at the state of Oklahoma and to give overall data of the program.
Thank you, Amy. Hello all, my name is Carrie and I'm the supervisor for our chronic care management team. And like Amy talked about, members with cardiomyopathy are managed by her team while they are pregnant. And they quickly identified this need to continue efforts beyond pregnancy. So referrals were made to my team of nurses so that we may build on the foundation that they have started and extend their care management efforts well beyond delivery. Our chronic care team is a group of 5 nurses and myself who offer ongoing case management for members who have chronic conditions like cardiomyopathy that can be impacted by lifestyle behavior changes. My team receives cases for cardiomyopathy in 2 ways. The first way is a referral from Amy and her team after delivery and completion of the high-risk OB program. Secondly is through data mining done by our data and quality teams for members who have delivered in the past year who also have a diagnosis code of 0903, and this is sent to us in a report. Next slide, please. We were able to identify 104 members who met this criteria, and all 104 women were offered care management services. Amy's team was able to offer case management for 59 of the women with cardiomyopathy while they were still pregnant. And then through direct referrals and through data mining, 85 women were offered care management after they had delivered. And this was provided in a few ways by our internal chronic care team and also by making referrals to one of our externally contracted care management partners through the health access networks. And they were able to provide face-to-face case management at the PCP's office, as well as telephonic case management like our teams. Additionally, we experienced a care delivery model change in the past year by implementing managed care. So some of the women were referred to our managed care entities for continued efforts. Let's dive a little deeper into the outcomes. Next slide, please. Of the 45 cases opened to my team, 20 women agreed to participate in the chronic care management program. And we call those members engaged. They are engaged with the nurse, they're answering the phone, and they are having those crucial conversations around their health. And we've looked at the outcomes of all the women identified with cardiomyopathy and compared those who did and did not actively participate in our program. The blue represents the women who were identified, but for some reason they were unable to contact or chose not to engage in care management. And the gold represents those who did actively participate with a chronic care nurse. I was really pleased to see the number of women who received care from a cardiologist. Both cohorts were in the 90th percentile. Of those engaged with a nurse, 19 out of the 20 women were established with a cardiologist. One actually declined that referral. She felt as though her cardiomyopathy had resolved and chose to manage her health needs with the PCP. All 20 of the women were aligned with the PCP, and we know this is huge for health outcomes. One member, or 5%, had an inpatient hospital stay related to cardiomyopathy. And of those engaged with a nurse, there were 0 ER visits related to cardiomyopathy. And overall, the best statistic is there were no deaths among the entire group. Next slide, please. Pictured here is Susan. She is one of the nurses on my team, and this is a case she brought to our team huddle a few weeks ago. Karen delivered a healthy baby girl in December, and by January, she developed cardiomyopathy and experienced a cardiac event that landed her inpatient for heart failure, peripartum cardiomyopathy, anemia, chest pain, and respiratory distress. Our data mining picked up on diagnosis code 0903, and her case was identified for care management. Susan, our chronic care nurse, engaged the member using motivational interviewing and found that upon discharge, Karen was prescribed Entresto, furosemide, and metoprolol. At the time of their conversation, Karen had run out of Entresto and was doubling up on her furosemide. At that time, she had not followed up with her PCP and was not established with a cardiologist. Susan did the social determinants of health assessment and identified that a barrier to care was reliable transportation and gas money. Susan assisted with scheduling a PCP appointment and arranged transportation and gas reimbursement through our Sooner Ride program, and coordinated with the PCP for a referral to a cardiologist, all while teaching the member how to navigate the healthcare system. Some of the key elements to care management success have been monthly calls with the nurse, but more frequent calls up front. And this is really to establish a relationship with the member and to knock out some of those immediate referral needs. Ensuring the member is aligned with a PCP and a cardiologist, and the member is making time for those appointments. Then addressing social determinants of health and behavioral health needs, and then diving deeper into medication education and adherence, and supporting lifestyle changes using motivational interviewing, all with the goal of member self-management, not only of cardiomyopathy, but all of the identified chronic conditions. And I cannot imagine the health outcomes for Karen if Susan didn't have those crucial conversations through care management efforts. And this story and so many like her are exactly why we do what we do every day. The next slide has our contact information. Thank you so much for having us, and please share your questions or suggestions. We are so curious to know what has worked well for other states.
Thank you, Amy and Carrie. We'll now turn to questions and discussion, and we have an active Q&A portal at the moment. So I think we have time for just a couple of questions. Let's start with one about engaging with Medicaid beneficiary. How are you working with OBGYNs and or primary care to communicate the purpose rather of the chronic care management unit, and what are you doing if there is apprehension or either reluctance to participate in the program? That would be for the Oklahoma team.
Sure, absolutely. This is Carrie. And participation with one of our chronic care nurses, it's completely voluntary. And the real goal is to reach out and connect with that person quickly. And part of that is through motivational interviewing. If I could drop one nugget for people to take away that engages patients and members quickly without this nurse-patient hierarchy, it would be motivational interviewing. Understand how to use that and connect very quickly, and then they can choose if they want to participate or not.
Great. Thank you for sharing that. Another question is about how Oklahoma is coordinating outreach with Indian Health Services.
I might jump in on that one, Amy,
Go
unless
ahead.
you want
Go
to.
ahead. No, you go right ahead, Carrie.
We have an entire department dedicated to our tribal outreach. And I have personally attended several of the tribal councils where all the different tribes come together and meet and talk about the challenges they are facing, the barriers that they have, and we bring what they suggest back to our policy and our data people, and we try to work together. So we have an entire team dedicated to bringing tribes into this mix.
Great. Thank you. Let's move to a question for our CDC presenter. Or actually perhaps for, CDC and maybe CMQCC related to aspirin. Can we talk a little bit about if there is an allergy to aspirin, and or if you could say a little bit more about the effectiveness for preeclampsia, the known effective for preventing preeclampsia, oh my goodness. If you can talk a little bit more about those, that solution.
This
If
is
there's an
Janet Wright.
allergy. Mhm.
Yeah, I think Dr. Williams is best positioned to talk about the allergy issue.
Right.
I will just say that what we've learned is that the use of electronic health record algorithms to identify individuals with these high risk and moderate risk factors lift up those individuals for clinical decision making have been shown to be very effective. And these women literally are hiding in plain sight within care, but not being detected in a timely way. And I think Dr. Williams referred to that. I'll turn the microphone over to her, though.
Thanks for the question. So in terms of aspirin allergy, we do not have a known alternative at this time. But if a person would be at increased risk for developing preeclampsia, we would certainly recommend them getting a home blood pressure monitoring cuff, or even better yet, remote blood pressure monitoring in order to follow as soon as those blood pressures start increasing. In terms of how effective it is for low dose aspirin for patients with one of the high risk conditions or two of the moderate risk factors, decrease in preeclampsia by 15%, decrease in preterm birth by 20%, decrease in fetal growth restriction by almost 20%, and decrease in perinatal mortality by more than 20%. So these are incredible impacts of such a simple intervention. And so we've got to get the word out into communities. And so, yes, we need the docs to make sure that they are screening appropriately, but this is something that can be done with self-assessment and then brought to your provider. And we're really hoping that our community and public health colleagues will be very active in this prevention effort as well.
Thank you so much. Let me go back to Oklahoma for a moment. In addition to educating Medicaid members on how to better navigate the health system and self-manage their chronic conditions, did you discover any changes that could make that navigation easier or, simpler for Medicaid members? And while you have the floor, if you can talk a little bit more about the data mining, if you are only using claims, is it certain codes? What else you might share about that?
Amy, you may be able to speak more to the data mining.
So our analysts, I am not 100% sure of everything all the different claims, all the different, claim numbers that they use. But I know that there are multiple different codes that they do pull, and they use eligibility, they use claims eligibility, they use they just use multiple different. I'm not an analyst, so I don't actually know everything that they use, but I know that we have our analysts that pull it all together, and then they actually send me a list of members every month that I go through. So what was the other questions that went along?
What was the first half of that question?
The first half was just about Medicaid and education of Medicaid members to navigate the system.
Absolutely. We do that in the chronic care team, and Amy does too, and her team. And it's through this relationship, this building with the member. So on conversations, hey, I don't understand how to get to this specialist. And are you engaged with your primary care provider? Have you chosen one? Would you like to change? Do you trust that provider? And it's walking through each of those steps as the issues arise. And then we can teach them hands-on to get to our website and learn how to get to the member toolkit and understand all these little extra benefits that they have. So it's hands-on, and it's usually a partnership with the nurse.
I will also say, in regards to that there seems to be, that I've seen with my case management, that if a member has like things in their life like food, safety, housing, clothing needs, and they those are not addressed, they're not going to be ready to make the health needed changes. You really have to make sure that they have the basic needs of life.
Yes,
and
those
so
social determinants of health, they're huge.
yes, it's very important, and we try to really try to break those barriers down and reach those needs so that they can drop their shoulders and be ready to make those changes, because if they're not able to feed their kids, they're not going to take care of themselves.
Yeah,
So
I have $4 in my pocket. Do I really want to spend that gas money to get to the doctor, or do I need to save that to add to next week's paycheck to pay my electric bill? Yeah, and then those are real.
So I'm sorry, but yes. So thank you so much. I think those are really important items. We have a webinar coming up related to collaboration with AIM, but related to what you just talked about. If you can go to the next slide, please. Well, the one after that. We do have an announcement that we really needed to make and wanted to make sure that you all were aware of. It's a new opportunity available through the Center for Medicaid and Medicaid Intervention, or CMMI, through the new Transforming Maternal Health Model, or TMA. The TMA model is closely aligned with MIHI initiatives that aim to improve maternal health outcomes. And the centers have worked together to do some alignment. Social determinants of health, the last question you were just addressing, is certainly a component of this model that will be addressed and states supported to address to improve maternal and infant health outcomes. So I invite individuals to check that out if you have not already. Next slide, please. Additional resources are available at the website. And as we close out today, if you could, we would invite you to answer the survey. And if you have any additional questions, reach out to the Medicaid and CHIP QI mailbox. I wanted to thank all of our panelists today. We had so many questions, we didn't have a chance to get to all of them. But the slides will be posted within a couple of weeks, which also contains the contact information for additional outreach to those presenters. Thank you, everyone, for joining us today.